Hello everyone, my name is Seher Ali Khan. I'm a GP with an extended role in dermatology and a sessional GP here in Leeds. Today I'd like to talk to you about collecting skin scrapings for mycology. It can be a real diagnostic challenge when you see a patient presenting with a red, scaly, unilateral rash, as seen in this image here. If it's scaly, try and scrape it. Fungal infections usually have a very well-defined leading edge. And if you do see a unilateral eczematous eruption on the hand or the foot, think fungal infection. And the reason why I'm saying pick a camp here, is it eczema or is it fungal, is because it's important to try and avoid combined antifungal steroid creams. The reason being that when you apply steroid to a fungal infection, it can really mask the symptoms and cause a condition called tinea incognito, which you can see here. So when you're unsure, please take a scraping and consider a trial of topical antifungal treatment, such as terbinafine cream twice a day, or if you're suspecting a yeast infection, try an azole cream, and review that patient in 3 weeks' time with the mycology results. To highlight this diagnostic uncertainty, can you guess here which one is which? Which is eczema or which is tinea? The image on the left is tinea with this well demarcated leading edge, and the image on the right is eczema with this scaly erythematous plaque. I'd like to talk to you about some practicalities of skin scrapings. Firstly, identify the edge of the fungal skin infection, because this is the area where the most viable fungi are likely to be present. Secondly, collect the skin scraping by using a blunt scalpel blade, such as a blade like this, or snap a wooden tongue depressor in half. Then you want to hold either the blade or the tongue depressor at a slight angle to the skin and take the scrape, collecting a good amount of skin flakes. Finally, package the skin flakes into a Dermapak packet or a folded dark paper, or use a universal white container. So I'd now like to do a practical demonstration with my lovely assistant here, who will provide her arm. So I'd like you to try and snap your wooden tongue depressor roughly in half, then angle it towards the skin. Get your Dermapak ready to catch any flakes, and all I'd like you to do is just scrape the skin so that you're at an angle there and collecting a good amount of skin flakes. Then once you've done that, you package it up by folding the envelope and sending it off for mycology. The mycology result will come in two parts: microscopy and culture, which will determine whether this is a dermatophyte, a candida, or a mold infection. A positive microscopy result is diagnostic for a fungal infection, even if the culture is negative. In the event that you're only able to get a small sample and a small amount of flakes, microscopy will be given priority over culture. Just a quick tip on dystrophic toenails. If you're suspecting a fungal toenail infection and you have dystrophic discoloured toenails, please try to cut the nail back as far as possible through the entire thickness of the nail and include any crumbly debris, because that's where the fungal infection will be. And finally, if you're taking any samples from the scalp, please include the scales and try and either pull or pluck the hair for a carrion, because cut hairs are not suitable. I'd like to talk a little bit about tinea capitis and the treatment of it in primary care. The top two images show tinea capitis in skin of colour and fair skin. Suspect tinea capitis in any child with hair loss and or scale and or regional lymph node involvement. Scarring alopecia following inflammatory tinea capitis can result in permanent bald patches. And we've seen this increasing popularity of skin fades, which may be contributing towards this. A carrion that you can see in the lower left image is a highly inflamed lesion of tinea capitis. And finally, when we look at the scalp with dermoscopy, we can see scale, and we can see these broken hairs with black dots, and also comma-shaped hairs. Tinea capitis is usually treated with oral antifungal treatment, and this is based on mycology results. And often we find Trichophytum tonsurans, which we treat with terbinafine, for 2 to 4 weeks. The dose is based on weight. Liver toxicity is incredibly rare. However, the BNF does advise LFT monitoring, and we generally would check LFTs after 4 weeks of treatment. For children, Grisula fulvin can be more effective against Microsporum canis, and it's important to treat all family members with ketoconazole shampoo at least twice a week for 2 weeks. I'd like to signpost you to the PCDS guidelines for Tinea capitis, which are concise and incredibly helpful. And also a note that the DART RADS tool is due to be updated soon. Thank you for listening. If you have any questions or would like any training or support, please email me at seheraliKhan@nhs.net. And if you'd like to provide any feedback, please scan the QR code on screen. Thank you.